declined accuracy,
Rồi, xong rồi.
significant head
Tí nó quay
or
đó,
body
quay.
movements, or poor tracking indicates that
Má ơi, đại luôn á,
it should
nói
rule
gì?
out that ocular motor dysfunctions.
Anh Ấn chịu rồi, con nghe đâu.
And this is a CSI score. It is very
Nghe chứ là
useful
biết giọng
in
anh Ấn.
it's a symptom questionnaire, very useful in the therapy.
Bữa ông kia vậy hay hơn.
And then we have discussed about all those classifications and testers, all those things. Now that we have complete diagnosis in our hand, so we move on to a management treatment. The treatment is not random. It depends on the patient's ACV ratio,
Dạ.
as I mentioned before, which is a primary tool. The patients with high ACV ratio responds well to optical treatments such as plus and minus lenses.
Dạ, ok.
In contrast, if you see the patient with low ACV
Không múc
ratio,
đầy cái này luôn.
they benefit more from vision therapy and in selected cases a relieving prism. This decision tree helps us choose the most appropriate treatment for each patient.
Bữa cách đây ngày tử mà
Treatment, this is a pyramid. The treatment should, it's like an architecture of a therapy. Treatment should always follow a structured sequence. We begin with an accurate diagnosis, and the foremost and very important thing is the patient education, because it improves the compliance. Next, we improve the visual efficiency by training the accommodation and virgins and the oculomotor skills. Once these are stable, and we focus on symptom relief. And finally, we integrate these skills into everyday visual performance for a long-term success.
Cái chồng nó là một hộp nó bán trên Shopee là đến trăm mấy rồi.
This is an overall a symptom like a symptom mapping of an accommodation. For example, when a patient's symptoms often provide certain diagnostic clues. Patients with accommodation insufficiency tends to hold reading material farther away. For example, in accommodative insufficiency, you can see a premature eye fatigue, a generalized headache, and a classical behavior cues in the tabular column. The patient with accommodative insufficiency holds a reading material abnormally far away. They avoid near taskers, and if you see in the accommodation excess, the intermittent variables, especially after the prolonged work, near to distance focus slow, and they also experience the photophobia. And in OMD, the ocular motor dysfunction, loss of place while reading, they use more blur and mix together. Movement of a print or a poor stability is fine. And this is the mapping of, the symptom mapping of aversions. This slide focus on the symptoms associated. You can clearly see, however, the symptoms has been mapped with the specific condition. There is a high CSA score, which is greater or equal to 21. This slide focus on a symptom associated with the virgin anomalies. The patients with convergent insufficiency complain that the words move or overlap while reading and may cover one eye. Even in convergent excess, commonly the frontal headaches has been arrived during the new work. In divergent excess, it produces a distance diplopia, especially when the patient or he or she is driving. Whereas in the divergent excess, usually presents with an outward eye turn in the bright light or during a fatigue, and not, and you can find that a daydreaming is found in the divergent excess. And next is the AC by and A level lever concept. For example, this slide explains why treatment depends the AC by A ratio. Uh, in low AC by A ratio, changes in the lens power produces a very little change in eye alignment, making lenses less effective. However, in the high ACB ratio, when you compare a low ACB ratio with a high ACB ratio, even a small lens changes produces a significant alignment change. Therefore, the lenses are highly effective in managing the high ACB ratio conditions. Let's now discuss the most common binocular anomaly, which is nothing but the convergent insufficiency. It is characterized by the greater exophoria at near. You all know that a resident NPS is found and reduced PFE, positive functional versions. These patients experience eye strain, headaches, and poor reading concentration and often avoid a prolonged near work because of the visual discomfort. And now, specifically, the treatment, the management of convergent insufficiency. Management follows a stepwise any refractive error. It's a universal law. So any disorders, any anomaly it can be. The first and foremost, thing to correct from an optometrist is that to correct the patient's refractive error. And the gold standard treatment is always an office-based vision therapy, which has the highest success rate. For patients who cannot undergo therapy and a relieving Dyson prism may be prescribed. Surgery is rarely required. Importantly, pencil push-ups alone not considered an effective primary treatment. The vision therapy progression. Vision therapy itself follows a structured progression. The phase one, you can find the smooth and tonic versions. The goal is to teach the voluntary convergence and normalize the smooth positive versions. The tools which has been used that you can see that will be using the block string and a variable tonograph. And the phase two is to increase the speed. The goal of phase two is that to train the jump and phasic versions, it increases the speed, accuracy, and to normalize the NFE. Like negative fusional versions. The tools used are the aperture rule and eccentric circle. Finally, we interpret the versions, accommodation, and eye movements so that the patient can perform everyday visual tasks comfortably and efficiently. And now we'll be stepping into the our next disorder, the divergent insufficiency, um, where esophoria is greater at distance. Reduced, you can find the reduced functional versions. These patients usually comfortable at near, but they experience the intermittent distance diplopia, especially while driving or when fatigued. The symptoms are mainly related to the distance viewing. You can see in the right side of the picture, it's a specific terms. This one is the most important slides, because not every patient with distance esophoria has divergent insufficiency, so we must differentiate. So this slide shows the differential diagnosis. We must, as an optometrist, we must differentiate it from the neurological condition, such as the divergent paralysis and the sixth nerve palsy. So we should rule out the both things. True divergent insufficiency is a chronic and it's committent. Whereas the neurological condition presents with sudden onset, it can be an incomitant deviations or associated with neurological sign. Therefore, any patients with acute distance diplopia should be referred immediately for a neurological evaluation as well. After ruling out, the before slides, continuing with that, the neurological causes, we can confidently manage the true DI, which is the divergent insufficiency, since it is a low ACB-A ratio condition. Prisms play the primary role in the treatment. We first correct any refractive error. As I say, it's a universal thing. Then prescribe a relieving basin prism to eliminate the distance diplopia. Vision therapy may be added if symptoms persist, while surgery is reserved only for severe cases that do not respond to the conservative management. We now move from the low AC by A condition to an high AC by A pathway. Unlike like the patient is AC by A, these individuals respond very well to changes. If the problem is conversion excess, uh, we if the problem is conversion something like if the problem is conversion excess, the we use plus lenses to reduce excessive near convergence. If it is divergent excess, target the minus lens and can stimulate the accommodation convergence, improve the distance alignment. And moving on to the next slide, the conversion excess characterized by the normal distance alignment, but the excessive convergence during a near work. These patients commonly presents with near esophagia, and they have a reduced NFE, negative functional versions, and difficulty with minus lenses. The primary treatment here is a near plus addition, which reflexes the accommodation and reduces near foria. Vision therapy is then often to improve the divergence ability, while the prisms are required only in the selected cases. And these are the pictures of a Brock string barrel cord. You can see the picture of patients with Brock string training vision therapy and a barrel cord. And you can see the aperture rule for a convergence therapy. Finally, we have a divergent excess. Here, where exophoria is much greater at distance than at near, patients often notice an intermittent outward deviation, especially in vision therapy, uh, like when a tired or a bright sunlight. The first line treatment is office-based vision therapy to improve the distance convergence control over a minus lens, may be used temporarily, particularly in children. And while surgery is considered only for large and persistent deviations. The unified strategy. This slide summarizes the entire management approach. The first step is always to determine the AC by ratio and high AC by condition respond to the best to the lenses, whereas the low AC by ratio condition requires a complete vision therapy or a prism, regardless of the conditions. We must always correct the refractive error and keep on insisting that is it's a universal basic thing, and surgery should be considered only as the final treatment option. And vision therapy for accommodative insufficiency. We now move to the accommodative rehabilitations. Vision therapy for accommodative insufficiency follows four progressive phases. You can see in the slide. For example, the first phase, the monocular rock, goal is amplitude and equal lenses. You can use heart chart and letter. The phase two is biocular rock and prism and flippers. And in phase three, you can find the separate, and in the phase four is flexibility. Uh, I want to mention the clinical pair is that the goal is to attain the equality between the two eyes individually. The goal for an accommodation accommodative range, you can see in the slide, with pleasant middle lens are always dependent by the age. And finally, we train the accommodative flexibility with rapid, near, and distance focusing, mm, helping a patient achieve comfortable and efficient vision in their daily life. And these are the pictures of a rod chart for accommodative rock. You can see the aperture rule, the figure 7.6, and you can see the loose lens rock in figure 7.4. And now, so far we have discussed the accommodative insufficiency. Let's look at the accommodative excess, where the goal is completely different. instead of strengthening accommodation. Also, note that along with the office-based therapy, uh, the home-based when the home-based therapy is adapted and followed, it gives us a better result. The results, I mean, the articles have been
100%.
highly highlighted that when both
Rồi.
office-based vision therapy and home-based vision therapy is combined, it gives a better results for the patient. And Getting back to the accommodative access to learning to release, the boxing is an excellent train tool because it provides immediate visual feedback to achieve the proper the alignment. This is supported with office-based relaxation exercises and simply home activities to improve the accommodative controls.
Rồi. 100%.
These are some slide, some
Tôi ghi lại
articles,
rồi, xong rồi.
reliable articles.
Xong quá, ghi lại xong quá.
The one thing you can see in these articles is that the prevalence rate is very high. Like it's in
Xem
many of
video.
cases it's asymptomatic. I hope you can see the slides. And whatever condition always starts with an accommodation therapy and stabilize the accommodation first, then start with versions. Because once a therapy should always begins with accommodation. Right. Okay. As a clinician, our treatment decision should always be an evidence-based. Uh, Research strongly supports, and also want to mention something about the articles. This article shows the prevalence of NSBVA, a non-strabismic binocular vision anomaly, and a need for the vision therapy, which has a high prevalence rate. Right. So, the office-based therapy for conditions such as convergent insufficiency, accommodative dysfunctions, and divergent excess, uh, it's equally very important to recognize its limitations. Vision therapy does not treat the dyslexic or a learning disabilities or an autism. Treating associated with visual problems may improve comfort, but it does not address these underlying neurological conditions. Right. So we have covered the overall classification, managements, and the treatment approach, everything else. Let's now apply everything we have learned to a clinical case. Uh, we have a 20-year-old college student with an eye strain and a blurred vision during a prolonged reading. Uh, Although visual acuity and the refractive error and vergence range in NPCs are normal, the accommodation findings are abnormal. The patient has, I mean, the case shows that the patient has a reduced accommodative amplitude, low PRA, and failure on accommodative facility, and an increased MEM lag. Keeping all this suggesting a problem with an accommodative rather than a vergence. So, using our diagnostic approach, we must first consider the convergent excess because of the near esophagia of the patient. However, the normal vergence findings ruled it out. The significant reduced accommodation amplitude, low PRA, and failure with the minor strengths, and increased monocular estimation lag all points towards one diagnosis, which is the accommodative insufficiency. This demonstrates how a systematic analysis helps us to reach and diagnose accurately, and it's very patient benefited. And now, stepping into the management of the case, once the diagnosis is confirmed, the treatment should address both system and underlying cause. We begin with patient education and prescribe a low near addition to provide immediate relief. At the same time, remember that we start a structured vision therapy program to improve the accommodative amplitude. and flexibility. We also advise the visual hygiene, including a 20-20-20 rule, and review the patient after 4 to 6 weeks to monitor improvement and how there's been the hot shake training will be used. You can also monitor the virgins monitoring, a visual hygiene adverse, and a very important one is the follow-up schedule. Right. We have discussed and reviewed our concept with all those slides. Let us review our concept with a few questions. In this question, the patient has exophoric near with resident point of convergence. What will be the like? You can find the popping out of polling questions. I'd be happy you will answer.
Em set up cái tắt cái kia đi, hay lắm, mấy cái này hay lắm, nói chung là hay. Observe em cái bên công ty đối trần á,
Right.
là nó xuất nhập khẩu. Thì em chỉ cần nói
Okay.
với lại bạn bóc
So if you see the first question, right? Yes, that is correct. It is convergent insufficiency. So, like, this is the classic presentation of convergent insufficiency, making it a correct diagnosis because the exophoria is greater at near with resident and near convergence. Right? That's most of them have been answered correctly. The next question, and the classic sign of CAE is a greater exophoric apnea, the previous question. Stepping on to the next question, the patient struggles to rapidly change focus from a board to notebook, which is condition is mostly likely. And you can find the options, the accommodating infacility, accommodative access, and hyperopia and divergent access. We'll wait for the answer. That's fine, that's perfect. Most of them has been answered correctly, 76%. Yes, the answer is accommodative infacility. This represents the accommodative infacility, where the problem is focusing on the flexibility rather than focusing the strength. The next question is, which finding differentiates divergent excess from the basic exophoria? We have reduced view amplitudes, exophoria, grade, normal stereopsies, and the near.
Còn một cái chiêu nữa cực kỳ hay, cái chiêu này là cực kỳ hay em mà vai trọng lên em thôi. Đó là nếu mà em muốn là em đang sử dụng cái atropine để thực hiện cái thực
Wait for the answer.
cái chiêu đo nó đang dùng tính cái kiến thức này.
Mày Nguyên qua tao đi cạo chọc đầu vào ngày mai tao cạo chọc đầu Nguyên qua này.
Great. That's perfect. The answer is exophoria greater at distance because it's significantly greater at distance and near. And basic exophoria, one of the key sign. We'll move on to the next question. And the fourth question is, which lens is commonly prescribed for convergent excess? Since it has a high ACP condition.
Luôn ship rồi sao nữa nó cũng là mới nhưng còn kia là hàng review, tức là hàng đã được sử dụng, tức là em đã sử dụng rồi nhưng áo em nó sẽ thích mặc áo sida là áo mới, em thích áo sida dĩ nhiên giá nó sẽ rẻ hơn chút.
Perfect, that's perfect. 66% have been answered it correctly. Yes, it is a plus lens for near. It leads to reduced convergence demand because the plus lens reduce the accommodative demand, and we can give binasal patching also. I just want to mention that we can also give a binasal patching for such patient. Right. Great. Many are answered very correctly.
Sao nó không cho cầm một tay sáng giờ tao có thể cầm một
hai là UV mới nhưng hàng
And our final question describes the patients with a normal ACV ratio retain. Which condition is most likely when both BO and base out and BI versions, base in version facilities are reduced despite of normal ACV ratio?
Đúng rồi, nó vẫn khá nhiều thôi. Còn thằng kia nó không khá nhiều. Còn tại sao thằng Lưu Smith giờ mới có, nó vô trẻ, nó vô thị trường Việt Nam sao? Bổ nhất.
Chạy yếu rồi. Như một chiếc
Đúng
con
rồi,
yếu rồi.
thằng mới vô. Còn thằng Jovi nó vô đầu luôn.
Chạy tụi nó nghe tiếng súng
Nhưng mà
rồi,
thằng
nghe đâu
Jovi
nó
là chưa
yếu.
nói chuyện bắt.
And also, I'd like to mention that the only condition where both NF and PV is low, even though they have normal ACV ratio. That's perfect. It's functional version dysfunction, right? With this, I have completed the diagnosis, investigation, and management of the binocular vision and accommodative anomalies. The systemic approach using the ECB ratio, appropriate clinical testers have covered the evidence-based treatment helps. I hope you have enjoyed it. Using an accurate diagnosis and successful patient outcome. Thank you for your attention. And then I'm happy to take any questions.
Nhưng mà anh lại nói trước nguyên anh dùng 0.05 lên xét hỏi uy tín. Nhưng mà thằng Huy bữa nói là 0.01 được rồi. Người ta thấy xài 0.1 người ta xài 0.5 cho xịn. Nhưng mà rõ ràng á là dĩ nhiên nó đưa ra ý kiến của nó nhưng mà quan điểm bằng không biết không làm.
What is CSI score? See, CSI score it's a symptom score. Like you can use that in vision therapy. It's a clinical tip. Always start training patient from their convergence and divergence ribbon, so it will be very easy. Like when you use the CSI questionnaire, it rules out the it's a symptom questionnaire. Keeping that, you can uh, find the underlying causes, and when you do vision therapy, if this keeping that scores, you can move on. You can check the reliability of the vision
Nó không
therapy.
thể không mà nó chỉ 0.1 thôi. Ủa mà hết rồi. Thì khi nó bơm cái một thì anh dạ dày và nhiều sắc nó không có tắt, nó vẫn ra nó vẫn kết hợp thôi cái sinh hoạt.
Also, I want to mention about CSIs. It is used to measure something like system quantitatively and something. Something quantitative and qualitative analysis of a therapy. What are the questions? Greater than, for example, greater than 21 considered as abnormal. As per my knowledge, the first starting of vision therapy should be virgins, and then for accommodation. Like it's up to the therapist, but how do I understand that anything which is has disorders, it should begin with an accommodation, because once the focusing is, when you train the focusing first, the accommodation system, you can easily align the teaming, which is a virgin system. So we always I'll be beginning with an accommodation first. Like it depends upon the vision therapist, but see, the reliable source will be better to begin with an accommodation therapy first. What binocular vision normative values do you
nhưng mà bác có biết nhiều hơn mà nhưng trong Nam thì thằng Huy nó lại rất là mạnh về
patient should dispatch?
Hello, xin chào tất cả anh em là tiếp cho nên em có rất nhiều chơi ngày hôm nay chúng ta sẽ qua xem những cái món đồ chơi không phải gọi là sở thích nhất của em ấy, xem em có những món đồ chơi gì. Thế hôm nay chúng ta cùng quay trở lại với phiên bản nâng cấp hơn của nhà đấy, đầy đồ hơn và nhiều đồ hơn và
Yes, the Ensuko test has a gross grading for 0 to 5 norms, like from for more secades and smooth pursuits.
thì anh muốn là xem là ngày hôm nay trong căn phòng này thì những món đồ gì bị mất kiểm soát. Chúng ta cũng bắt đầu với những thứ mà là những thứ mà tôi ít dùng.
Đây là một cái điện thoại của nhà
Đây. Nhưng mà nó không được gì để em mua cái này. Em có một lần em ra xuyên đội đồ bảo là cứ xà là nó vào hết tất cả đĩa đệm, nó
In this
dẫn bắn
case,
lên
I mean, which question is
nó vào hết tay.
like it's better to go on with a
Chúng ta sẽ
CASS
có một
questionnaire.
cái gọi là cái một món đồ trên cái kệ này thì đây. Đầu tiên là chúng ta có một
And
cái
also, I just want to mention that we can stabilize ACP ratio using I mean the CSA score, the Schumann and Wick normative values. It will be more easy to analyze.
lần đầu tiên
Oh, guys.
bất giác anh vừa nhìn thấy
Chưa để gửi mới ngắn.
một cái treo hình thôi, một cái mèo chân thôi, nhưng mà bây giờ tôi mới thực hiện thực sự là nó là một cái đề kính. Không ai biết đây là một cái đề kính. Mình bán mình bán là link là gì nhỉ? Đây là bản nâng cấp của mình tòi
Your
này.
opinion.
Trước là có được một cái của em ấy tặng nhưng mà nó
What is the likelihood of success ahead with therapy at the clinic? What points do you think? In my opinion, like the patient's consistency lacks in the home-based therapies. Like if it is a vision therapy, if the therapy is an office-based, it gives more much reliable results.
đỡ chắc là được có 10-20% so với tổng thể, mà nói chung ấy anh cứ hiểu là em rất là nhiều lời em quá tốn tiền với con này, nó rất là quá tốn tiền đấy, cái máy này mua giá khá là
As for patching for convenience sufficiency, when you patch the binasal thing, you can find a better results in the therapy.
Ngắn à? Rồi biết rồi.
đây em có thể gửi cái đoạn này sau nhé. Được đó nhỉ. Quay đây là em đùa con mèo em một cái máy này tí, nó mang tính chất gọi là kiểu kiểm soát con mèo nó đang ở đâu.
See, always do start when you talk about the accommodation. It's not about like teaming. How do I start? Is that like you can start binocularly if it is an accommodation.
Có khi em đi ra ngoài là em hay bật nhạc cho con mèo nghe, sợ nó sợ chết rồi. Ôi yêu thương mèo đây này, đúng luôn nào.
Không có slide tiếng Việt. Nghe đi anh.
Dr. Trần Trọng Duy.
Which is the best source to learn baby? Which is the best source to learn? Practice it. Practice the baby. Like repeat the tests. It's you can learn more efficiently. So the best source to learn something like books or all, practice it. And the binocular vision written by Shimon and Vic helps us to guide, the better understanding about the binocular, like the BV assessments. Like procedures. Multiple questions popping up. What kind of therapy you prescribe for children, like ASD, ADHD, while ages start with or visual power integration? See, as I mentioned that these ADHD and autistic oral children, we cannot, manage the underlying cause. We are just treating only the visual problems. I will also like to mention that the one thing, to get a better reliable vision therapies, add a prospective training, like a balance training, all those stuffs.
Nếu mà mình để lên lúc đó thì nó sẽ giảm cái lương chính xuống, nó làm giảm lương nghiên cứu, nó sẽ làm kia lên, nó sẽ cho cái
Always start a vision therapy with full prescription.
thứ hai là trong vòng khoảng chừng từ 3-5 năm nữa thì nó sẽ xây một cái bệnh viện.
What else? Currently, kids are having high hyperopic when checking its psychological function. Any possibility of treated radiation
Nó sẽ
scan?
là một cái trung tâm mắt nữa, trung tâm mắt, rồi xong rồi đúng rồi, rồi thêm nữa thì có chuyện đó.
And also, I want to mention that the prospective training, we should train their visual motor skills along with vision therapy. It gives a better improvement. So we like I love sports vision. So I done my PhD in sports vision. This prospective training in an athletes, it does wonders. So it's not up to the, I mean, the high end supernormal vision athletes. Even with the vision therapy, we can start with a minimal amount of proprioceptive training and balance training. It does wonders in the patients.
Rồi chết mày rồi.
So
Đúng rồi,
it's
cao
training the
khoa
vision and balance, eye,
Giờ gì
body, and
đâu.
nó
mind.
không được khoa nữa, nó chỉ là một cái phòng khám thôi.
It's made more on a cognitive facility.
Mua camera, mà camera còn đầu tư được.
Despite of normal.
Sao vậy đâu?
Nhưng
A
mà
patient with Excel was presented at 100
nhưng mà được một cái đi không? Nó đông lắm mày ơi, nó đông nghe không?
Do ACV ratio respond to accommodation? ACV, not directly, but indirectly it supports the accommodation. I mean, it responds to the accommodation. But the peculiar thing here is that ACV ratio is completely within. It has a high role in the virgin system, but even it has some role on accommodation. But it responds very minimalistically, not up to the mark like a virgin system. That's like that only if there is a focusing is better, I can team it up. It's like a bullock cart riding with two horses. So if I wanna go fastly, I need two horses to perform better.
Bây giờ chủ cả cuối của hoàng ấy nó chụp xong là xong, cái thằng cuối chụp nó
Poor
là
feeling
xong,
management. What to do?
đi lên một cái chiều đại.
In patients with both strabismus and binocular vision dysfunction, what guides your decision better than surgery and prism?
Rồi, thằng
À
sẽ
bên
giao.
họ gì á, không hôm nay chỉ biết có bạn nó là thao, thao thì nó là cậu con linh trong mình yêu không, nói chuyện ra vậy nó là carbon.
Like in patients with both strabismus and binocular vision dysfunction, what guides
Nhưng mà nó có
your
cái không
decision between surgery?
thì cái
Uh,
trong anh quay ra
it's
cái
about
ảnh
the, I mean, when I done with the complete
chuyện như
evaluation,
tử nó kêu để
the
nó nuôi cái
quantity is
biểu đồ
it's highly matters.
rồi từ
And
đó
it's
anh mới biết được
see, it's a broad spectrum.
mức mà làm vi
It
tưởng mà
depends
tự được
upon the specific disorders,
thì lúc đó thì
and
anh
the overall
anh
evaluation and the data we get, I mean, from the
bây
from
giờ
the patients, and the overall
bạn nên
diagnosis
tải em
and the
nhà
clinical approach and the treatment
nó liên quan gì lại
modality.
bây giờ thì là lâu
Only
nó
then
hỏi
we can, I mean,
Lan thì nó
talk
biết
about the decision between the surgery or a
nó
prism or
thằng
vision
tí
therapy.
tí
So
mà bên
always
Korea
first
Vancouver
begin with a better vision therapy.
mà thằng tí thì có thì anh
And
dạy cái này
I mean, the
lại thì
quantities were,
đừng có
like,
đẩy
it's very
cái
important
nó
while
lên
doing the vision therapy.
mày đẩy gì mà khủng quá mày đẩy mà đẩy người ta làm người ta kêu mày là bị nó đá thì nó đẩy là 65 mét nhưng mà trả nó cho nó việc trong vòng 1 năm.
That is from Kenya. Thank you for
Cái
joining
gì
from Kenya.
thì anh mới nói
Kenny.
nó đá 65
What
mà đem
questions?
cho
How
một
do you
một
usually
2 tháng
therapy patients?
là ở trong
How
một triệu
far should you
ở
flow
trong hai
treatments?
ở trong hai
That's
ở
it.
trong nó bị khùng của
Do you
mày
have any questions?
anh nói em đẩy gì cho yên tâm mất công đó là đang làm với trường công viên nó vô mất thẳng em đi nó bây giờ quan viên không mất rồi đâu là quan
Diagnosis
viên nó
also
cản
once
mày
you in
cái
clinical
con
case.
ngân á cái con ngân lĩnh ruột quan viên con đó bây giờ nó là lính cuối cùng á con thì con đó nó
Also, I want to
nó chịu cái gì
mention some point like
nó
my
nó ngồi
accommodation versions
thì
team
cái
up to make it happen
ở
in
đây
the
đứng khoa mày là
vision
một
therapy
cái gì
sector.
18 tháng
So
nha
it's like, as I said before, it's
là
like a two
con
horse.
cứng đủ cứng để đứng một cái bệnh viện hay không
That's point of a vision therapy. Like the final
và
goal is
ngoài
to
con đó
get
thì quan
single
viên
and a
còn
clear
hay đâu
vision.
con thấm thì cũng đã nghỉ rồi
Please
con
note,
quyên
extend
gì đó cũng
treatment
nghỉ
takes
rồi
time, regular
cuối
exercise,
cùng quan
and
viên bây giờ
patients
là con khỏi mất
percussion to achieve good results. Should we explain
thì
these
bây giờ
patients,
mày cứ
especially
mày
if
có
they
điên
have
mà
already
cứ đi
been
trường
referred to a
phải
neurologist by
có
now?
nghĩa là mày phải có mức hợp lý
It's very good
anh
question.
chấp nhận
I mean,
còn mày
you
đi
check
mức
it
trình
out the
trời lại chấp nhận
emails. See,
để
patient thinks that
nó lại
see,
lại để
vision
nó chỉ
therapy,
có em
the ophthalmology patient,
anh
it's,
Tuấn hồi
it's
sáng
not a
anh
simple
không
5 minutes or a
có
10
một
minutes
vàng phải qua
prescription
để cái gì nó qua
way
cái
of
gặp
treatment.
Tuấn xong
Vision therapy is a
nó đưa
long-term
một cái list
process.
danh sách
It's
học
like
cho mình
when you want to
rồi
train your body, you
thứ
need
nhất á
a
là
complete activities
em
or a
phải là
long
trưởng
time
khoa
gymming. The same
và
thing when you
em
want, I
phải
want
là
to
người
train my
đứng để
brain. See,
trang
you know
trải
that
một cái
60% of our
liệu
brain
sử
activity is
liệu
completely
đó
related with
thì giữa bác sĩ
the
với
ocular
người
activity. So in that case, if I want to build my muscle, I need some time. Certainly, vision therapies also need some time. This is the only way we can convince the patient. So it's a overall, I mean, a long term treatment, and also we should explain that. um
quyết định mua là không có
the
đảm bảo
results
em
are
mua
not
cho em là
instant,
tháng 7 tháng
but
tháng 9
in
là
the
cho
long
kẹt chưa được
term way of
rồi
treatment,
cầu á
it does
mày thích
wonders.
mua thằng kia này là
Like
hàng tháng sử dụng
if you heard
rồi
about the
second hand
patients
mày
with
hàng
better
new
result
mày
in
cũng biết
long
phải
term
là logistics về chứ
therapy.
đâu là
So
có
the
đâu là
patient
có
results, to promote the
thứ
vision
ba tháng
therapy,
là lương
we need
lương
to
của mày
first
có được chi
educate
vậy
them.
chi ba ba
The one
ba
thing is
ba
that
tháng
they're not aware.
một á
They
là
have been
200 triệu
usually seeing the
lương cho 12
instant
tháng thứ
treatments,
ba
but vision therapy,
là 300 triệu trả liền cho em luôn
it does wonders
ăn cho
only
em liền
when you
luôn
give when we give time, because
rồi
it trains the brain.
cái ngày đi
It
làm của
goes on
em
with
á
the axons.
là cứ 1,5 triệu một ngày 1,5 triệu một ngày rồi nếu mà doanh thu nếu mà 1,5 triệu một ngày cứ ra thì phải ổng mày trung bình
For
65 triệu á
divergent exercise,
nói chừng 65 triệu một năm á
will be using
65 triệu một tháng
a
một
basin prism can be used for prism therapy for a divergent axis.
40 40 40 là 40 triệu 40 triệu cộng 25 triệu
Difficulties and challenge in vision therapy.
là 65
The difficulties and challenge in vision therapy is that it's not instant process, so we should continue for the long term process. That's a very main difficulty, and it's not very easy to understand. Like patients from the different types of like in the different types of fields, or else you can find the other departments, they can easily understand it's just a prescribing manner. But when we talk about vision therapy, we just want to convince them it's a long term process. The only difficulty is that it's a long term process, but when the patient waits and accommodates it, it does wonders for the patients.
mày tiêu sao cho nó phù hợp
That's it.
mày
Any other
mày chơi
questions from
tố
my
mày gọi là
colleagues?
tố mày chơi tố lương á mày sai quá
Right.
bây giờ
Thank you all.
thằng điên đi á nó chỉ trả cho anh á là
And finally, I'd like to
45 đến
thank
50 thôi
side by side Andy and all the team for the opportunity. It's been a privilege to
rồi
present.
bây giờ
Meet you all.
850 view.
chưa ông bữa nó nói sơ sơ là 45 40 đến 45 là cái được 50 đâu mà rót nha mới ghét rồi nha muốn còn có 30 là còn 30 đến 35 là còn không đảm bảo bao nhiêu là em số mổ đâu thành ra là nên đi thành ra đi về làm quá gì cái thứ hai
Nói chung Hoàng nghe em được phết đấy chứ nhở?
đúng rồi thành ra đi về mổ mà nó bây giờ nó chỉ có một ngày nó chỉ có nó có một lần hàng tuần là đứng thôi đứng mổ thôi còn cái đá còn lại là chủ yếu là nó đi khám các tuyến nó chỉ có 2 tháng đi khám các tuyến để mà về không có mổ mà bây giờ nó đang chuẩn bị mở một cái ở Vũng Tàu một cái ở Đồng Nai không phải nó nói là ở Vũng Tàu với Đồng Nai thì
Thế
có
là
thể
một sáng vẫn còn hơn 600 anh em ở đây.
không nó mở thêm nó mở bệnh viện á nhưng mà bây giờ anh hỏi em biết bây giờ mở nhưng mà bác sĩ thì mày trả lương vậy thì mày kiếm đâu ra thứ hai á là bây giờ cái lượng bác sĩ mà là kiếm được coi như là đại đa cho mày bao nhiêu người mày kiếm bao nhiêu người mà nếu mà không phải tự nhiên mà ông kiếm không nghỉ đúng không tự nhiên ông kiếm không nghỉ bao nhiêu tay cũng về là không biết đâu chứ là phải có vấn đề